Okay, am I audible to everyone? Okay, so today's topic is to address some challenging topics from the physiology. So many candidates ask me some queries regarding ECG changes in the pregnancy and some hormonal regulation during the menstrual cycle. So I have made the preparation. Before proceeding, I would like to revise and recap some of the important physiology topics which are important, and you need to cover these topics before writing the exam. And these topics include acid base changes during pregnancy, the electrolyte changes during the pregnancy, which includes calcium homeostasis, and you would also going to cover this topic again in the endocrinology as well. Osteoporosis, which is also relevant to the hormonal balance of the parathyroid hormone. So this is a high yield topic. You may find some questions in the biochemistry, in the physiology, and in the endocrinology as well. So you cannot skip this topic. The next thing is the CVS, in which you need to cover cardiac cycle, ECG changes, CVS changes during pregnancy. You may get a lot of SBAs from this topic. So this is a high yield topic. And today I have made a presentation which is particularly focusing on ECG changes during pregnancy. Soon I'm going to cover that. The next domain you need to cover is respiratory changes during pregnancy, how a female body is going to adapt during the physiological changes during the pregnancy. You need to memorize the maternal and fetal gaseous exchange and how do the carbon dioxide transport happens in the mother's body, and the exchange of oxygen and carbon dioxide between the fetus and the mother. Next topic is GIT, which is an easy topic. Urinary system, that's again very important because it covers many urogynecological questions from the SPAs. So this is important topic. When you go system wise, you will see in the anatomy, in the physiology, in the pathology, this urinary system holds a very major portion from the SPAs. So this is a high yield topic again. Then the female reproductive system, in which you are going to I understand you have already done physiology, so you must be covered these topics: folliculogenesis, menstrual cycle, hormonal changes during ovarian cycle, menarche, and menopause. Then the male reproductive system, you need to cover spermatogenesis, semen analysis. We have many SPAs from the semen analysis in which they give you some findings and ask you the diagnosis. And sometimes they just give you some normal semen analysis report, and you have to answer that this report is normal. Then the nervous system, in which you need to cover action potential, neurotransmitters, and physiology of autonomic and sympathetic nervous system. The last but not least is the fetal and placental tissue, in which you need to know about amniotic fluid composition and measurements, fetal urine and swallowing, fetal membranes, fetal lungs. It seems like a big topic, but it contains very small information. You just need to remember the basic information and the basic values, the normal values. Cardiopulmonary adjustment at birth and structure of placenta. Now, the most important topic, which many candidates ask me, like how we can study ECG and how we can find out, how we can interpret the changes during pregnancy. So it is important to interpret ECG during pregnancy with caution by the gynecologist, because many times the doctors sitting in the emergency department came across several ECGs in their daily practice, and many times it happens they label normal physiological changes during pregnancy as pathological because they don't have much understanding of the ECG of a pregnant lady. Like some changes are physiological and they label them as pathological. Pregnancy causes various changes in ECG and should be interpreted with caution. And this is not only important for the exam purpose, this is also very important for your clinical practice, that you should have better understanding of this basic ECG of a pregnant woman. so that you can that would help you in the better management of your patient, and especially for those patients who already have cardiac condition. So you should be in a better position to discriminate between physiological change in the ECG and the pathological change in the ECG. So it's a very important topic in the clinical practice as well. So there are 5 major things you need to remember. You can memorize like this. You have 5 fingers and you have 5 changes in the ECG during pregnancy, which are physiological, not pathological. So what are these 5 changes? Number 1 is the left ventricular hypertrophy. Number 2 is the apex is shifted entirely and to the left. Apex of the heart. Left axis deviation 15 degree. Inverted T waves in lead 3. Q wave in lead 3 and AVF. And I understand this is not making any sense to you right now, but I will break down each and every change so that you can memorize it easily. But remember, for exam purpose, there is no need to go in the deeper information or have plenty of knowledge. You just need to memorize these 5 points, because this exam is a very straightforward exam. They don't keep you in the gray area. So they ask you simple questions and the answers are very simple. So it's better to memorize these 5 points, but with better understanding. So I'm going to break down everything. I wanted to ask you some questions. Is this left ventricular hypertrophy is pathological or physiological? You can give your answer in the chat box. Let me check. Okay, please tell me, what is the difference? Could you please give me more examples of physiological hypertrophy? Yes, it's physiological. Give me one more example of physiological hypertrophy. Okay, I will come back to this question at the end of the session. Till then, you can find the example and also give me the example of pathological cardiac hypertrophy. Okay, I'm giving this question and I've asked the answer in the end. One example for physiological cardiac hypertrophy, physiological hypertrophy, and one example of pathological hypertrophy. Let me go back to my slides, and I don't know why I always skip my slides. Okay, I need to start again. Okay, so these are the 5 changes. Okay, anytime when you're going to study any ECG in your general practice, always you should know about the normal ECG. If you know about the normal ECG, then it's become more easier for you to detect any pathology or any abnormal changes. So it's always important to go through from the normal ECG. So I have pasted this normal ECG. Let me give you a quick recap. I understand you already know about the normal ECG, but just for a recap, normally we have 3 limb leads, which is lead 1, 2, and 3. 3 augmented leads, which are V3, VL, VF, and 6 cardiac leads, which are chest leads, which are V1, V2, V3, V4, V5, and V6. So this is a normal ECG graph. And in between these leads, you can see the QRS complex, which is a normal in any normal ECG. So we always find QRS complex, P wave, QRS complex, and ST segment. So what is P wave, QRS, T wave, ST segment, and QT interval? Because these are the things we need to check to interpret any ECG. So what is P wave? P wave indicates atrial depolarization. That means when SA nodes fire in the right atrium, it causes its depolarization, which ultimately give us a P wave on the ECG. Then there is ventricular depolarization. When that happens, when electrical impulses pass through the ventricles, they gave us QRS complex. The next thing you can see is a T wave. T wave indicates a ventricular repolarization. That means the cardiac muscles are going back to their relaxation state. ST segment indicates early ventricular repolarization. Q2 interval represents ventricular depolarization and repolarization. I have another question here. Where do we find the atrial repolarization on the ECG? My question is where we can find atrial repolarization on the ECG, because until now we have P wave, QRS, T wave, ST segment, and QT interval. All of them are showing atrial repolarization or ventricular depolarization and repolarization, while the atrial repolarization is missing. You can drop your answers in the chat box. I will address that in the end of the lecture. And I'm asking this question because we have SBS. So that's why I just want to put that thing in your mind so that you can remember till the exam. This is a better picture of the normal ECG. You can see P wave. When this happens, when the depolarization of atria happens. Then we have the QRS complexes again, which happens due to depolarization of the ventricles. In the last picture, we have T wave, which represents the repolarization of the ventricles. This is another picture. I just wanted to make sure you understand this topic completely. So I have added an ECG graph, a picture with ECG graph. You can again see P wave, QRS, ST interval, TP interval, RR interval, and everything you need to know about normal ECG. Another thing, the small box of an ECG graph is equivalent to 0.04 second, and the big box is equal to 0.20 second. These are the things you need to remember so that you can, when you are going to study abnormalities or any changes, you are able to detect those changes. Okay, so here is the picture. Let me recall, as I mentioned earlier, that we have 5 fingers, so 5 changes in the ECG during pregnancy. So here is a picture of these changes. I'm going to break down one by one. The first change is increase in the heart rate. As you can see, before pregnancy, the number of QRS complexes are less, while during pregnancy, you can see more number of QRS complexes are present in each segment. But that means the heart rate is increasing. You can, for example, if you're going to calculate the heart rate, you can see if you have more QRS complex, then that's obvious that you are having increased heart rate. And we know, we have discussed in the last session, the reason why a female have increased heart rate during pregnancy is due to increased cardiac output. Then we see the Q wave in lead D3. I have better pictures in the coming slides, so don't worry about that. I will address that. I will just address everything one by one in the coming pictures. Another change we have studied that there is left ventricular hypertrophy. The reason behind is that, again, is due to increased cardiac output. There is increased workload on the heart muscles. They have increased 40% of cardiac output. So that's why muscles have to adjust that workload. As a result, they become hypertrophied. So this is the justification of second change. Okay, increased heart rate, sinus tachycardia, and why we are saying that it is sinus tachycardia. That means the rhythm of the heart rate is normal. How we can see the rhythm? If the RR intervals are at the same interval, like if you count the small boxes between two RR intervals, they are equal in number. So that's why it's sinus tachycardia, which is physiological in pregnancy, and up to 120 beats per minute is acceptable. Then another change is short PR interval. As you can see, normal PR interval is 0.12 to 0.2 second or 3 to 5 small scares. And this is the ECG of a pregnant lady. And you can see this interval is shortened. We have just 3.5 small squares between P wave and R wave. So it has been shortened. Again, what is the reason this PR interval is shortened? The justification is same. There is increased workload on the heart, cardiac output is increased, tachycardia, the heart is beating rapidly, so that's why this PR interval is shortened. So this absolutely makes sense. This is a tricky thing. If you have a better background knowledge of the cardiac physiology, then you are in a better position to understand this topic. However, I'm here to help you. I will try my best to explain this thing to you. So I mentioned that we have a right axis deviation of the heart at 15 degree. So what is this axis deviation? What is that? So we do the ECG. We know that the cardiac activity is basically electrical activity. And the purpose of doing ECG is to apply a current so that we can see the ion changes and electrical changes in the heart. So it is all about polarity. And we see and we usually see the lead 1 and lead AVF for the axis of the heart. So these two leads are important for the axis assessment of any heart. So if you see, okay, what is this positive and negative means? Positive means the QRS complex is facing upwards in the ECG trace, and negative means the QRS complex is facing downwards. In coming pictures, I will show for the better demonstration. For now, just remember this thing. If the lead 1 and in the lead 2, the QRS complex is facing upwards, that means it's normal axis. If one is facing upwards and the other is downward, that means it's a possible left atrial dysfunction, deviation, left atrial deviation. If one is negative, other is positive, that means right axis deviation. If both are negative, then we say extreme axis. For now, you just need to remember about the pregnancy, because in the exam, they are just going to ask you about the ECG changes in the pregnancy. So just remember the normal value and the pregnancy value, which is right axis deviation at 15 degree. Now you can better understand. Here you can see in the blue circle, the QRS complex is facing upwards in the lead 1. But when you see in the lead AVF, the second circle on the third line, the QRS complex is facing downwards. That means it's negative, and on the lead 1, it's upwards. So this is axis deviation during pregnancy. However, in normal ECG, both the QRS complex are facing upwards, which is normal. But now here one is in the opposite direction, the polarity is changed, which is pathological, but in pregnancy, we say it's physiological. Am I clear so far? If you have any question, please, you can ask in the chat box so that I can address that in the end, and I don't want to miss any of the query. The next change is inverted T waves in the lead 3, V1 and V2. And as you can see in the lead V1, V2, I highlighted this. You can see the inverted T waves. Usually they are, when I show the normal ECG, the T waves are facing upwards, which was normal. But in pregnant lady, these are facing downwards, which is significant when we are looking for myocardial infarction or ischemia. They are pathological, but in pregnancy, they are considered as physiological. Okay, so I wanted to explain I wanted to give you a quick recap of this axis changes and the physiological changes of the ECG in the pregnancy. I'm going to recap. The change one I mentioned was the sinus tachycardia, which is due to increased heart rate. The second change was Q waves, which are significant determining particularly about the diagnosis of MI. By that means where you are seeing these Q waves, because it's important that Q waves are different in pregnancy. They may be not more than 3 small squares. If in pregnancy you find the Q waves more than 3 small boxes, that means it is pathological in pregnancy. So this is very important to differentiate between MI or ischemia between physiological changes. Okay, and there was another thing, the change of the apex of the heart position. The justification behind is that when a female is pregnant, her diaphragm may pull upwards. That's why the heart's position slightly changed. This is the one reason. The other reason is the gravid uterus. Because of the uterus, the heart's position may be slightly changed. The axis moves towards more on the left side. So this is the justifications of all the physiological changes during pregnancy in ECG of a pregnant lady. Okay, I think I should move forward towards our module 4. Which is endocrinology. Let me explain you what is the significance of endocrinology in the RCOG curriculum. It plays a crucial role in RCOG curriculum as it addressed hormonal aspects affecting reproductive health. Understanding endocrine disorder is essential for managing conditions like PCOS, polycystic ovarian syndrome, thyroid dysfunctions, and diabetes in context of OBS and gynae. So this is a high-yield topic. So I wrote some high-yield topics from endocrinology, and I oftenly repeat this thing. The purpose of giving you the high-yield topics is not that you skip rest of the topics. You have to study rest of the topics as well. But this is just a focused approach so that you can have a better understanding of these important topics, so that you can easily able to manage 40 to 50% in your exam, which is close to passing ratio. So the high-yield topics from endocrinology are polycystic ovarian disorder, thyroid disorders. And when you're going to study thyroid disorders, you have to study what type of drugs are suitable in pregnancy or not, and everything related to thyroid disorder. And what could be the management in the 3rd trimester and 1st trimester and everything. Diabetes in pregnancy, hyperprolactinemia is very, very important. Hormonal contraception. Okay, you can leave the hormonal contraception for now because we have this section in clinical management of OBS and gynae. But you can go through from that topic for now, but you can leave it for later as well. Menstrual disorders, menarche, puberty, and menopause. These are also very important. They ask you some questions like at which age, which pubertal changes has already been happened. So they have some SPS from this topic. And adrenal disorders. Okay, this was also some candidate asked me this question to make a video on this topic, hormonal regulation during menstrual cycle. This is a topic from physiology, but I have mentioned this topic in endocrinology because it was hormonal related, and it would help you in covering many endocrinology topics as well. So let's start this topic. Okay, so this is a tip, whenever you are going to study endocrinology, please start from hypothalamus and pituitary gland. You cannot afford to miss these 2 master organs, especially the pituitary gland, because they have this negative feedback response, and they are controlling all of the hormonal mechanism in our body. So we cannot go on in endocrinology without going through hypothalamus and pituitary gland. I used to study endocrinology like that. Whenever I studied any topic, maybe it could be thyroid hormone, parathyroid hormone, or any of even pancreatic hormones, I used to start from hypothalamus. Okay, so as you can see from the picture on the top, we have hypothalamus. Why hypothalamus is on the top? Because it secretes a gonadotropic releasing hormone, which causes the production of hormone, which are follicle stimulating hormone and luteinizing hormone from the interior pituitary. This topic is have many SBAs. One SBA is which I observed from the recalls. They have a question: how hypothalamus connects with the interior pituitary gland and regulates its hormone cycles. So you can drop the answer: how hypothalamus is connected to interior pituitary and transfer its hormones. In female reproduction system, hypothalamus produces gonadotropic releasing hormone, which travel to interior pituitary and causes to produce two important hormones, that is luteinizing hormone and follicle stimulating hormone. Please note, in males, both these hormones produced, but their effect is different because of different gonads. As you can see, in males, they produces effect on testes and produce testosterone, while in females, they affect on ovaries and produce estrogen and progesterone, which is a female hormone. Here is another SPA. Which hormone is equivalent to estrogen in males? So this is a high yield topic. Okay, a quick recap. We already know we have uterus and two ovaries, and these ovaries are connected to uterus by a fallopian tube. When we look at the ovaries, they are highly vascularized, and through these blood vessels, these hormones reach to the ovaries from the pituitary gland. Ovaries have, along with this high vascularity, ovaries have many follicles. But in each month, only some of these follicles begin to mature and convert into primary follicle, and out of only one can ovulate and become an egg. Okay, I have pasted this graph. I found this very helpful because it covers all the aspects of menstrual cycle, along with the ovarian changes, follicle changes, and the uterine wall changes. But today, I will be more focusing on the hormones. So let's consider today is the day one of the menstrual cycle. That is, female just have the periods and shed the uterine wall. So today is a day one. Within ovary, there are many primordial follicle, and some starts maturing into primary follicle, and just one ovulate. As you can see on the graph, on the left side, we have y-axis. On the y-axis, we have concentration of hormones in blood. And on the x-axis, we have the number of days of the menstrual cycle of a female. Normally, it's the cycle is up to 28 days. And this dotted line in the midline represents the mid-cycle, which is the day 14. Just to simplify things even more, we divide menstrual cycle into two phases. From day 0 to 14 days, as you can see on the axis, we have divided this phase into follicular phase. As its name represents, as follicular phase means something happens and something going on in the ovaries with the follicles. So In the first 14 days, the main changes are going in the ovaries, and everything is related to the ovarian follicles. And similarly, the hormones which are going to produce during that time in the body are mostly working on the ovaries and the follicles. So that's why it's follicular phase. On the 14 days, ovulation happens, and the next days, we call that luteal phase, from day 14 to 28 days luteal phase. And why we call this luteal phase? Because corpus luteum is going to form at the end of the cycle. Okay, now you can see the ovarian hormones. You can see they have a section of ovarian hormone and interior pituitary hormone, and they show the body temperature changes throughout the cycle, and they have shown the growing follicles, and and you can see that day 14 at the time of ovulation how the eggs came out, corpus luteum formation, and corpus albicans formation, which is degraded form of the corpus luteum. However, I summed up everything in these two charts because in this exam, we need to memorize this smart information. I'm just explaining everything because I just want you to better understand every topic, so you don't have to cram everything. So this is an easy way to remember the hormones, so that you cannot confuse anything. From day 0 to 14, what happens? The gonadotropin releasing hormone increases. And as I mentioned earlier, this GnRH is released by hypothalamus, which is the beginning of the menstrual cycle. This is the first thing which happens in the body during the day 1 of the cycle. What happens when GnRH increases? It stimulates the interior pituitary to produce FSH and LH. When we see at the graph, FSH increases, then drops. Luteinizing hormone increases, but there is a steady increase, and estrogen increases. Okay, here is a question. As we say, the gonadotropin releasing hormone is increasing. As a result, FSH and LH is increasing. Then why they have difference in the graph? Like one is increasing, then drops, and other is increasing but steady increase. So the answer to this question is. This is something which usually students confuse. Like, if we have equal amount of GnRH, then why we don't have equal amount of FSH and LH in the beginning of the cycle? The reason behind is that both of these hormones are acting on ovaries, and ovaries produces estrogen as a result of that. And this estrogen controls the FSH and LH. In the low concentration of estrogen, it affects the luteinizing hormone. That's why it remains steady throughout the cycle during the first 14 days. And when its concentration gets higher, it affects on FSH. That's why it increases and then suddenly drops with the LH surge. Then on the day 14, we have LH surge. You can see before the day 14, LH was increasingly but steady increase. But at the day 14, as soon as the ovulation happens, there is a LH surge. As a result of that, luteinizing hormone increases rapidly. Now, since we are in luteal phase, we don't need follicles anymore. And if we don't need follicles anymore, then this LH surge gives a negative feedback on the hypothalamus to stop producing GnRH. If gonadotropin releasing hormone starts decreasing, ultimately FSH and LH starts decreasing. So this is a very, this is a very common sense thing. We don't need any logic to remember this thing. We don't need follicles. We don't need FSH and LH. So the LH surge sends a negative feedback and stops production of this hormone. And yes, after LH surge, LH luteinizing hormone also goes down because we don't need follicles anymore. FSH decreases. Estrogen decreases. Okay, now this is a time when corpus luteum has been formed. So we should say thank you to the corpus luteum because it produces 3 hormones. The one is progesterone, estrogen, but in a very less amount. By that time, estrogen is just detectable and inhibin. And this is the hormone which sends the signals to the hypothalamus, act by negative feedback, and stop the production of estrogen, and the progesterone is increasing. I hope everything makes sense to you now. So I just simplified this topic because we have no time to remember a very any large theory topics. So you just, for the SBS, you just need to remember these things. Okay, now I'm going to address your questions and I will check the answers. Okay, Namra, your answer is right. Another physiological example of hypertrophy is athletes, which is skeletal muscle hypertrophy as a result of exercise. Yes, aortic Kiran, that's the right answer. Yes, MG Sheikh, this is the right answer. That's why we don't have atrial depolarization on the ECG, because it is a mass between atrial depolarization and ventricular depolarization. Yes, it is merged in QRS complex. That's right. Okay, I have asked a question about how hypothalamus is connected to anterior pituitary. This is an SPA from the past recalls. Okay, endogenously. Okay, any other answer? This is from the past recalls, so that's why I'm asking this question again and again, that how hypothalamus is connected to anterior pituitary. We have an answer which is endogenously, and any better answer? Okay, the hormones from the hypothalamus travel to the anterior pituitary, and the hormone is gonadotropic releasing hormone, particularly about which we are talking about, is through the portal circulation, through the blood supply. This is the right answer. I'm gonna write the answer. If you find in the SBA's hypothalamic hypophyseal portal system, go for that. If you find in the options through blood circulation, go for that. If you don't find any of these two options, then you go for the pituitary stalk. Thank you. I hope everyone understands ECG changes during pregnancy, because that's a tricky topic. Although you just need to remember 5 points, but it's a good idea if you understand the basic things, because it would help you in the clinical practice. So being a doctor, being a gynecologist, it's important you know the basic information and concepts. Thank you. Okay, since we have already started our fourth module, which is endocrinology. Let me give you some tips how you can cover your endocrinology this week. And yes, you can do another thing for me. You can any topic, if you find any topic difficult or confusing, you can let me know in the chat box or in the WhatsApp group, so that I would be better prepared for tomorrow's session. Okay. As I was talking about this thing earlier, like how I used to study endocrinology, and I used to start from the very basic thing, like from the hypothalamus, because all the releasing hormone. Yes, we have another SBA. They sometimes confuse you by changing just a single word. Sometimes they mention about the hormone secretion and hormone storage. So, keeping this thing in your mind, usually hormones are secreted from the hypothalamus, and they are stored, they are produced by the hypothalamus and secreted by the anterior pituitary. So, these are two different things, the storage and the secretion, production. So, sometimes they ask this such kind of questions in the exam, which are very simple questions, but they are tricky. Like I'm going to give you an example about the gonadotropin releasing hormone. It is released by anterior pituitary. Let me find the correct statement of this question. Okay, just keep in mind the hormones are stored in the anterior pituitary, but they are secreted under the influence of hypothalamus. So just remember this line. Yes, sure. I can give you some examples. Actually, I don't have SBS with me at the moment. I'm just when I was going through from the lecture, I was just remembering these questions. Okay, how to deal with those tricky questions? Okay, so the only trick is that read the statement carefully. Don't rush in solving SBS just to save your time. If you read the statement correctly, and you read the options correctly, 60% job is done. Okay, for endocrinology, I'm gonna tell you some topics which are other than those high yield topics, which are also important. You need to know about the sex hormones, both in the male and female, and their functions. In most of them, we already know about these. What are ovarian hormones? We know that estrogen and progesterone. And in Oxford Vision Notes, they have mentioned almost 14 more hormones which are produced by the ovaries. Tamina, I understand that, but all you need to stay focused while reading the statement and the options. Okay, initially everyone get confused, but once you practice these SBS again and again, and you have a better background knowledge, this is no big deal. You can easily solve the questions. For now, don't panic about this thing. Just you have plenty of time till July, so try to clear your concepts and practice SBS as much as possible. And when you are going to do recalls, then you will realize how many things you already know. Okay, I was talking about sex hormones. We know the male and female sex hormones. We should know the functions of these hormones, the very basic functions. Then we should know about the hypothalamic hormones. This always, again, I'm repeating this again, whenever you are going to study endocrinology, please start from hypothalamus. You should know about the hormones of hypothalamus. You should know about the pituitary gland structure, that how many lobes pituitary gland have, and what are the hormones which are produced from the anterior pituitary, and what are the hormones which are produced from the posterior pituitary. Okay, here is another SPA. As I asked you how the hypothalamus is connected to anterior pituitary is by hypothalamo-hypophyseal portal system, but this is not correct for the posterior pituitary. The hypothalamus and posterior part of the pituitary gland is connected via nerve innervation. So this is a difference, and these both things are in the SPs. Okay, moving on to the next. When you have done hypothalamus, pituitary gland, then you have to cover a high yield topic, which is hyperprolactinemia. We have many SPAs from this topic. In Oxford Revision Note on page number 208, I guess, they have that table in which they give the physiological finding, the pharmacological findings, what kind of drugs affect the prolactin levels, and what are the common pathologies. So you should memorize that table. The next gland is the thyroid gland and the thyroid gland hormones. Again, for the thyroid gland hormone, you have to start from the hypothalamus. Let me give you a quick recap so that you can cover this topic now, and later on you are just left with the pathological findings and some of the drugs. So what happens, how the thyroid gland hormones are formed? It all starts from the hypothalamus. The paraventricular nucleus of the hypothalamus produces thyrotropic releasing hormone, thyroid, which acts on anterior pituitary As a result, thyroid stimulating hormone is formed, which then act on G protein coupled receptors of the follicular cells of the thyroid, and the thyroglobulin synthesis, which is a protein, is formed. After this, it triggers the production of in the follicular cell T3 and T4. And once the T3 and T4 is formed in the liver, that hormone enters into the bloodstream. So how it is related to the gynae aspect. In the past recalls and SPAs, we have such questions in which they ask about the number of, like at what trimester T3 levels are at its peak, and at what trimester T4 levels is at max, and what is the level of TSH during the first or last trimester. So they have such questions. So you don't need to remember all the physiology, how these hormones are produced and everything. You just need to remember the things which are related to pregnancy and physiological change during the pregnancy. You need to memorize only those things. I hope I'm making sense to you. Please do let me know in the chat box if you have any queries, or if you don't understand anything, or if you are confused in anything. And do let me know if you are clear with everything so that I can move forward. I'm waiting for the reply. Okay, guys, I need a favor from you people. If possible, please drop a feedback from today's webinar in the chat box or in the WhatsApp group, so that it would help us to grow and improve ourselves, so that we can handle you guys in a better approach in the future webinars. It would be of great help. Okay, should I move forward to the next gland? Because I wanted to brief endocrinology today so that you can cover everything in the coming week. Okay, I was at thyroid gland hormone. I told you what kind of question you should expect from the exam. You need to know about the physiological changes in the thyroid gland synthesis during pregnancy. You need to remember those values, not exactly the values. You just need to know what T3 or T4 is increasing or decreasing during the first trimester, when its values is it's at peak, when the thyroid binding globulin increases or decreases. So you should know this. This is the very basic information you need to remember from the thyroid gland. The next topic is adrenal hormone. So you should know about the adrenal hormones, what type of hormones are released or produced by adrenal cortex and adrenal medulla. I remember we have done in biochemistry about steroidogenesis. We have covered some of the hormones, which are the cholesterol derivative hormone from the adrenal gland. We have covered that topic in detail. And we should know the pathologies associated with the adrenal gland. We have Cushing disease. We have Addison disease. We will cover these topics in the pathology as well. But it is a good thing if you covered these topics sidewise for the better understanding. Uh, then yes, I missed that high yield topic, which is renin-angiotensin system. We have many questions in the past recalls from this topic. If you want, I can teach you this topic in today's webinar because this is important. And why this topic is important? Because during pregnancy, there is a massive change in the electrolyte balance in the female body. It is also associated with high blood pressure during pregnancy, and these hormones also affect the placental fetal barrier, blood barrier. So this is very important to maintain blood volume and blood pressure. So as we all have the exposure of gynae practice, and we know the blood volume and blood pressure is have what kind of significance in gynae practice. So renin-angiotensin system is very important. This is a high yield topic. Then the next hormone producing gland is pancreatic gland. It have significance regarding diabetes. So you can cover diabetes under this topic. It's all up to you, but it's a simple topic. You just need to overlook, just give a good read of this topic. There's no need to memorize anything from this topic. Okay, now I'm going to tell you some endocrine diseases you need to cover which are mentioned in the RCUG curriculum, and the topics which are important and high yield for the exam purpose. So some of the endocrine diseases you need to cover is the syndrome of inappropriate antidiuretic hormone hypersecretion, which we called as SIADH. Endocrinology is very important. We have questions in the recalls from every of the gland. So we need to cover these topics, and please give plenty of time to the endocrinology. This is the core of this exam. So SIADH, I remember in my exam, I have a question from SIADH. We have the other diseases, diabetes insipidus, which is also related to SIADH. We usually make a table and compare SIADH with the diabetes insipidus because they have some similar findings. The clinical presentation of these both diseases are quite similar, so we have to differentiate. And the third disease we usually compare with is a simple diabetes. We compare these diseases, but mostly we compare SIADH with the diabetes insipidus. The next endocrinal disorder we need to cover is hypothyroidism, because we know at the time of labor, there is a sudden drop of blood supply in the brain and in the thyroid gland. So many patients present with hypothyroidism after the childbirth. So we need and some of them already have this autoimmune disorder of hypothyroidism, especially in the UK. So don't forget about you are writing the exam for the UK. So you need to be more focused on the diseases which are common in the Western countries in the UK. So in UK, they have the autoimmune disorders are very common. So many females have hypothyroidism in the UK. Then hyperthyroidism is far more common in Asia as compared to West. The next disorder is Addison disease. We cannot miss this topic, Cushing disease, Cushing syndrome and Cushing disease. Okay, this is another, we have SPAs from all of these topics. So I emphasize again, please understand these topics very carefully. Try to read their clinical presentations. What are the investigations you are going to order, and what kind of results you are going to get and how you can diagnose this condition. There is no need to remember the advanced management of the disease, but you should know about the physiology and pathology. And when you study Cushing syndrome, we again compare two diseases together. Cushing syndrome and Cushing disease, these two things, they sound similar, but they have different pathologies and different outcomes. Then we have Cone disease, pheochromocytoma, and prolactinoma. Done. So these are the pathologies you need to remember. The next topic is puberty. We have straight lines from the Oxford book in the exam. We have to cover Tanner staging in this topic. Then you need to know a bit about placental hormones, that what kind of hormones are produced by placenta and how they are important for the pregnancy. Then you need to study a bit about initiation of labor and how endocrine system is involved, both by maternal side and fetal side. What you should know about sorry, I was disconnected. Okay, I was talking about the hormones which are produced by the fetus, which trigger labor procedure. So how the labor is triggered by the fetus. So what kind of hormones are involved? So mainly, let me tell you, we have questions from this topic. Remember cortisol and DHEAS. Both of these hormones are responsible for the initiation of labor. And they are produced by the fetus, not by the mother. If you want to, I can teach you this topic in tomorrow's session, like what kind of hormones are produced by the mother and what kind of hormones are produced by the fetus, and how together they interact and initiate the labor process. The next topic is purpurium and lactation. This is not a high yield topic. Just give this topic a good treat, and that's it. Okay. It's better if you drop all of your queries in the WhatsApp group so that I can compile those topics and prepare the topic for tomorrow. And the last thing you need to study for the endocrinology is the fetal and neonatal endocrine system. It is a very, very, very short topic, just a single table. Like what kind of how the fetal endocrine development happens. Well, we study this topic in detail in the embryology section, but for now you just need to remember the hormones which are produced by the fetus and how they are going to interact with the mother. That's it. This is all about the introduction of endocrinology. I hope I guided you well, and if you don't understand anything, I apologize for that, and you can ask me. I can clear your queries. So this is the end of today's session. I'm here for more 5 minutes, so you can ask me anything, and you can drop a message in the WhatsApp group for any of your queries or any topic you want to learn from me. And please drop a feedback for us. Okay, everyone, thank you for the kind listening. Uh, Thank you, and see you tomorrow. Welcome, Rima. Thank you, Alia. The reason why I asked you for a feedback so that I can work on some of my deficiencies. Thank you, Kiran. Thanks again, Kiran. Okay, bye, everyone. See you tomorrow. Bye bye.